Neonate chapter masterclass web series. Today we have got two important pediatric surgery topic: pediatric thoracic emergency and pediatric neonatal abdominal emergencies. So we've got two well-renowned pediatric surgeons, and most of us know them in Bangalore because of the work they have done. So the first talk will be done by Dr. MUKUNDA RAMACHANDRA. He's a consultant pediatric surgeon and urologist at Rainbow Children Hospital, Bannerghatta Road. Thank you very much. We would like to extend a warm welcome on behalf of NNF Karnataka, our entire office, President, Vice President, Joint Secretaries, Executive Board members, and the entire NNF Karnataka members. A warm welcome for this webinar. Welcome, Dr. Mukund.
Thank you, Dr. Prashant.
So today we have really a very important topic where, as a neonatologist, we get confused at times. Do we have to refer, or when to wait, how long to wait? And it's very difficult for us to counsel the parents. Most of the centers may not have luxury of pediatric surgeon 24/7. So when they are available either once a week or on-call basis. So we need to have a clear idea of when to refer. Yeah, we need to have a clear idea about when to refer and how to come to conclusion and diagnosis. So to clear all our doubts and to understand the pediatric emergencies better, here we go. Dr. Mukund Ramachandran, I would request you to start the session. And most of the attendees who are attending today's webinar are neonatologists and practicing pediatricians who are practicing neonatology as well. So we will have discussion, question and answer session at the end of both the talks. So in between, I request all the participants to kindly mute their video and audio so that we don't have to keep on muting all and disturbing our presenter. Dr. Mukund, over to you.
Yeah. Thank you, the NNF team of Karnataka, to giving an opportunity for me to speak in this forum. So today I'm going to talk about pediatric thoracic emergencies, followed by my colleague, Dr. NIJAGAL MUTT, is going to talk about pediatric abdominal emergencies. So I'm a full-time surgeon at Rainbow Children's Hospital for the last 3 years. So I'm going to talk about the thoracic emergencies now. So I have divided this talk into two entities. One, children presenting with respiratory distress with a surgical condition underlying. The second, having a surgical diagnosis in the prenatal scan or an abnormal looking X-ray because it was done in the neonatology unit or in the pediatric ward for some symptoms the baby is undergoing. The first thing what I want to talk about, the pneumothorax in a neonate. Pneumothorax is one of the commonest emergencies what we encounter in a high volume center, and it can happen in 1 to 2% of term babies without underlying lung conditions, but it is more common in low birth weight babies. Up to 9% incidence is there. And other risk factors for pneumothorax are invasive ventilations or a very low birth child or pre-existing RDS. The clinical features will be very obvious. Child will be tachypnic. The work of breathing has increased. The SATs are going down. Then the first thing what we do in X-ray, you do a clinical examination and take an X-ray. So this is one of the X-rays of a child with suspected pneumothorax. In this X-ray we can see there is a small pneumothorax, but the lung is not totally collapsed. We can see the sharp edge sign where the cardiac border and the diaphragm can be easily seen. So this child requires a conservative approach where you can give oxygen with nasal prongs and periodically monitor for the saturation and whether to see that pneumothorax is increasing over a period of time. Majority of these kind of babies is going to get better with conservative line of treatment. The condition is a tension pneumothorax where the entire lung is collapsed. You can see this picture, the entire lung is collapsed. There is lucency all around the lung border. The diaphragm is flattened. the volume of the hemithorax is increased, the intercostal spaces are widened out. This is an absolute emergency. So this requires a chest tube drainage, because if you don't put a chest tube drainage, the child may go for a cardiac arrest because of the venous obstruction. When I talk about the chest tube drainage, all neonatology units the resident should know how to put a chest tube drainage, because we can't wait for an expert or a consultant or a senior person to come and put a chest tube drainage. By this time, it will be too much of time and we may lose the child. So we always use pigtail or sometimes suction catheter to decompress the lung. What I see in my unit is putting a drain is very easy, but my experience is fixing the drain is more important, where we don't do more manipulations, because every manipulation in a newborn child already compromised the parameters. It put a lot of stress on the baby and the recovery takes a longer period. So once you put a tube, we should know how to securely fix the tube, where further manipulations should be avoided as far as possible. So next I'm going to talk about the diaphragmatic hernia. This is one of the most common conditions what we encounter in our pediatric practice. So when I say diaphragmatic hernia, the left side is most common. There will be defect in the posterolateral aspect of the diaphragm, that is called as a postdilic hernias. The entire abdominal contents from the intestinal loops, the stomach, large intestine, kidney, left lobe of liver, the stomach can go inside, herniate into the left hemithorax, push the mediastinum to the right side and compress on the right lobe of the lung, and there will be respiratory distress and there will be cyanosis, and clinically we can see that decreased chest movement on the involved side. Abdomen will be scaphoid, absent breast on the left side. And once we see this kind of X-ray picture, the treatment starts in the delivery room whenever we have a suspected or a diagnosed case of diaphragmatic hernia in a prenatal scan. The important steps, what has to be done when the baby is born with a diaphragmatic hernia is, we should never give a bag and mask ventilation. Because when you give a bag and mask ventilation, already the left hemithorax is filled with the stomach and the intestinal contents. That is going to increase the air in those visceral organs and compromise the overall circulation, and the child may go for immediate arrest also. So what we do, don't give bag and mask ventilation. Put a nasogastric tube to decompress the abdomen. Keep the child NPO and give supplement oxygen, and we take measures to decrease the pulmonary hypertension. That may because we have to keep the temperatures in a normal range. We have to sedate the child because the work of breathing increases again the pulmonary arterial hypertension is required. We have to intubate and give adequate muscle relaxations and treat respiratory acidosis. And other tests are required to rule out any associated syndromes. So congenital diaphragmatic hernia is not a surgical emergency. Once the baby is born, shifted to neonatal intensive care unit, we wait for anywhere between 48 to 72 hours until the pulmonary hypertension is stabilized. Unless the neonatologist says go ahead with the parameters, reading on the serial ABGs, how the baby is responding to the ventilator settings, what is the PEEP is started on day 1 up to day 3. When everything is stabilized, we'll take the patient for surgery. The surgery can be done through an abdominal approach or through the thoracotomy approach. So this is one of the patient I operated. This is, you see the left hemithorax is completely filled with the intestinal loops. Once the diaphragm is repaired, you see the lung is expanded. We can see the vascular markings here. And this is the small pneumothorax that will act as a air cushion gradient for a hypoplastic lung to gradually expand over a period of 3 to 5 days. I don't prefer to put a ICD once I do a diaphragmatic hernia repair, because I want this lung to expand in a gradual manner where again secondary pneumothorax will not happen. So we can see the diaphragm is pulled up down, but over a period of time, in 5 to 7 days, the whole lung will expand it, and child can be discharged anywhere between 5 to 7 days after the surgery. So when I say diaphragmatic hernia, we should know other condition called as eventration of diaphragm. In the eventration of diaphragm, there is incomplete muscularization of the diaphragm, and because of that, the diaphragm is elevated. We can see the upper picture is the right side. The liver has gone up into the right hemithorax, and the left side, it is almost up to the third intercostal space. So when you say eventration of diaphragm is not an absolute surgical emergency. We can stabilize the child. It depends on the weight of the child, how much is oxygen requirement, but majority of the child can be managed symptomatically in the first month of life. After 1 or 2 months, the child can be electively thoracoscopic plication of the diaphragm can be done. But in some babies where the oxygen requirement is high, the work of breathing is high, if the lung hyperplasia is more, we should do the surgery in the first week of life only. But majority of eventrations can have a wait and watch policy approach, and we can the problem can be fixed after 2 to 3 months of life. Then I'm talking about the tracheoesophageal fistula. It is one of the commonest conditions, used to be missed maybe 5 to 10 years back, but right now because of the NNF program, lot of neonatologists are trained in many centers, and they are very, very comfortable in handling a suspected TEF and how they know how to diagnose a TEF, and appropriate referrals are happening now. In tracheoesophageal fistula, there is a discontinuity of the esophagus, and the lower pouch usually communicates with the trachea. So once the baby is born, we can see lot of frothing in the mouth and the nose. Or when you try to put the nasogastric tube, the nasogastric tube is not going to enter the abdomen. Sometimes if you have a good clinical examiner, you can see that abdomen is scaphoid. So so there are different varieties. Type 3 is the most common, where the lower pouch is communicating with the trachea and the upper pouch is blind. And other variants are there when both upper pouch and lower pouch is blind, where sometimes upper pouch communicates with the trachea and the lower pouch is blind, or there is a S type of fistula. The type 3 is the most commonest variety of tracheoesophageal fistula. See, how do you diagnose? Once you have a suspicion, we put a radio-opaque tube in the upper pouch and take X-rays. So as a surgeon, I would like to do this X-ray on my own, because I want to look at what level the upper pouch is ending. It should be at the level of carina. It is at the level of T4. This is very, very important, because it will tell us it's a short gap or a long gap, and it will helpful for me to counsel the parents what approach I'm going to take during the repair of the tracheoesophageal fistula. Once you see that the tube is not going down, then I look at the abdomen. If the abdomen has adequate gas, that means there is a communication between the lower pouch with the tracheobronchial tree. So it is a type 3 fistula with the upper pouch ending at the T4 level. I assume it's a short gap tracheoesophageal fistula. So the preoperative care before the baby can be taken for repair is very, very important, because the upper pouch is blind. There will be pooling of saliva in the upper pouch and will cause aspiration pneumonia. The goal of stabilizing the child with tracheoesophageal fistula is to prevent aspiration pneumonia, and for this thing we use something called as a replogal tube, where there should not be a direct suction into the upper pouch, because it is going to injure the mucous membrane of the upper pouch. That will cause a problem while doing the anastomosis, while doing the repair. That's why we put an indirect suction and keep the pressure between -15 to -35 centimeter of water, and prevent the oral secretions going into the airway and aspiration pneumonia. So other general things will be taken care of it because he had to elevate the head end of the incubator. Antibiotics will be given, oxygen will be given, and we had to work up for bacterial association because renal anomalies, cardiac anomalies, and abdominal skeletal anomalies should be done a baseline workup before taking up the child for definitive repair. So in the short gap, because when I know that the upper pouch is ending at the level of T4, we do a posterolateral thoracotomy, identify the upper pouch, disconnect the lower pouch from the trachea, and do end-to-end anastomosis and keep a tube, intercostal drainage tube in a extrapleural space.
Sir, please unmute yourself, sir.
Unmute, please.
Okay. It's unmute now. Can you hear me now?
Yeah, sir. You can start.
Yeah.
Make it full
So
screen.
I was talking about the repair. So once we have a short gap, disconnect the lower pouch from the trachea and do end-to-end anastomosis. If the short gap, the child can be start feeding after 48 hours. We can do the dye study, the barium swallow check for the to rule out leak, and child can be discharged on post-op day 5 or day 7. So then comes the long gap esophageal atresia. It is only 8% of the anomalies. In the long gap, the upper pouch is blind, the lower pouch is blind, and there is no communication with the tracheobronchial tree. So in this condition, there are some, we usually do a stage procedure, gastrostomy and the esophagostomy. Gastrostomy, put a small tube in the stomach for feeding purpose, put the esophagostomy in the left side of the neck to prevent aspiration pneumonia, and we do a gastric pull-up or a esophageal replacement surgery by 6 months to 8 months of life. This is what I told you. The gastrostomy will be put for the feeding purpose, and this esophagus will be pulled onto the cervix, left side of the neck. Then the esophageal replacement procedure will be done. So I am trying to work on work on this project like a Fokker technique. The Fokker technique is nothing but a esophageal lengthening procedure, because esophagus is not a tube, it's an organ, and if you give proper stimulus, it has growth potential and growth induction can be done, just like a gradual process. This is like any other growth induction thing like plastic surgeons do. They put a small implant underneath the skin, where over a period of 3 to 6 months, the skin will be expanded and they'll use for reconstructive purpose. The same principle will be applied here. In pure esophageal atresia, we do a thoracotomy, identify the upper esophagus, identify the lower esophagus, take multiple stage sutures, bring it out through the thoracotomy wound, and gradual traction will be given over a period of 10 to 14 days, where esophageal lengthening will happen. Once you achieve esophageal lengthening, because we'll have radiopaque markers at the end of these stitches, where we can do serial X-rays and monitor the length of the growth of the esophagus. Once we assume or document that there is enough overlap between the upper pouch and lower pouch, then redo thoracotomy will be done and do end-to-end anastomosis of both the ends can be done. This can be because this needs multiple procedures. First is esophagostomy, gastrostomy with these multiple stage sutures. The second is thoracotomy for end-to-end anastomosis. And if there is complication like stricture, requires bougie dilatation. But this is far, far better than the esophageal replacement procedure, because esophagus can't be replaced by any organ in our body, because when you use stomach as its own problem, we got a dumping syndrome. If you use colon doesn't have a peristalsis, the child will have halitosis. If you use jejunum, again it doesn't have a proper anatomical and functional properties of the esophagus. So this esophageal lengthening procedure is widely practiced in America or other European countries. But in India, because of various factors, always esophagostomy, gastrostomy will be done. Later, esophageal replacement procedure will be done if the child is 6 to 8 months of life. So, but this Fokker technique is far, far superior, where we can save the native esophagus and long-term outcome for the child is far better, and functional esophagus is far better than they replaced with some other structure. So this pure esophagitis will be managed in the same way what I just discussed right now. So other thing what you should have in mind in a neonatal unit is the S type of fistula. This is quite rare and we need high index of suspicion to diagnose S type of fistula. See, what is the important thing in S type of fistula is choking during feeds. The mother or the nurse who is going to do the pallada feeding is easily tells that child chokes and start coughing violently. That means some amount of milk will be going into the tracheobronchial tree. But when I say S type of fistula, the most common condition to have is gastroesophageal reflux. So then how to differentiate between S type of fistula and the gastroesophageal reflux? If you take an abdominal X-ray, abdominal X-ray shows lot of gas because of the air entering the abdomen through the fistula. So this will be treated as GER and it is strong suspicion to diagnose S type of fistula. How do you do this? We need to do a barium swallow with a barium should not be used. Sorry for that. So you should a water soluble contrast should be used. And we need a special technique to demonstrate it because we put a baby in prone position, insert an nasogastric tube into the stomach. In the prone position, start injecting water soluble contrast, a small amount, and start pulling out the tube. At some point of time, if you are lucky enough, we can demonstrate a very classical S type of fistula. But this is not always a scenario because if the child is small, child has got aspiration pneumonia, sometimes child coughs during the procedure, sometimes the dye will spill on into the trachea through the esophagus. So this is a little bit tricky, but if you able to have a persistence and patience doing this study, we can demonstrate a very classical S type of fistula. Still, we are not able to make out a S type of fistula in a water soluble contrast swallow. Then comes the bronchoscopy. The bronchoscopy always is diagnostic for S type of fistula. You always see the rigid bronchoscope. You see this is the right main bronchus. This is the left main bronchus. This is the carina. And we can see the elevated posterior surface of the trachea. And there is a fistula here. So bronchoscopy is almost diagnostic in case of a S type of fistula. Once you establish the diagnosis, what we do, the ligation of the fistula. The approach will be do a diagnostic bronchoscopy, put a guide wire through the fistula into the esophagus. Then, because it is level of C71, we'll take a right in the hyperextended neck. We take a transverse incision along the above the supraclavicular region, identify the esophagus, identify the trachea. With the help of the guide wire, just identify the fistula and ligate it. So once the guide wire has passed through the fistula through bronchoscopy, this is relatively easy, and to divide the fistula, and patient can be discharged in 3 days. See, always the tracheal fistula we should think of as a pediatric surgeon. I look at the child who is going to survive for next 60 to 70 years. The 68 years is the life expectancy in India according to WHO standards. Anything what I do, I looking at 68 to 78 years, 68 to 70 years for a newborn. Short gap, excellent outcome, no doubt about that. Long gap, there are problems like stricture, because we're going to pull the lower pouch, reflux may happen. So we had to follow up the child once the surgery is done. And I said very long gap when they're done a Fokker technique, we had to keep the child in a prolonged surveillance for GERD or failure to thrive, recurrent strictures. That has to be dealt by the pediatric surgeon. And I take the responsibility that everything is okay for the child and educate the parents that long-term follow-up is required for to prevent complications. So then I'm going to talk about the conditions per se doesn't present with respiratory distress, but whenever you do a X-ray for some other condition, you see a almost hyper like a pneumothorax kind of picture, but just is not any person going to see this thing is a pneumothorax on the right side, but it's hyperinflated one of the lobes on the right side. We can see it is the pleura is herniated to the other side, pushing the mediastinum to the left. This is congenital lobar emphysema. Left upper lobe is most common, followed by the right middle lobe. So majority of the children in the first 6 months of life or immediately after birth, they are asymptomatic. They will come anywhere whenever there is a respiratory tract infection or repeated wheezing or chronic cough. Then whenever the pediatrician take an X-ray, we'll see this kind of picture. See, whenever you see a congenital lobar emphysema, this is the lower image is a congenital lobar emphysema, the upper image is a pneumothorax. People have mistakenly diagnosed as a tension pneumothorax for congenital lobar emphysema and put an ICD. So how to differentiate? In a pneumothorax, the collapsed lung always goes to the hilum of the mediastinum. In CLE, the lobe is near the diaphragm. And if you see carefully, you can see the bronchovascular markings in the hyperinflated lung. Here, the lung borders are very clear and there is lucency around the lung border. That's how we differentiate a pneumothorax with a CLE. So once we X-ray is more than enough to diagnose a CLE, but sometimes in a especially ventilated child who is on the ventilator for a long time, we should rule out secondary causes, like for a mucus plug obstructing the airway causing secondary CLE. But CT, what is the importance of CT? See, you have to see how many lobes are involved. What are the other parts of the lung are okay, or still there is any undergoing pathology. So this CT will tell us one lobe involvement or multiple lobe involvement and status of the other side of the lung. So once we diagnose CLE, see if the symptoms are mild to moderate, that means the work of breathing is not there. There is no respiratory distress. We can wait for 1 to 2 months of life. If it is child is severely dyspneic, is oxygen dependent, we have to do an emergency thoracotomy and resection of the involved lobe. But anesthesia and the care in the NICU sometimes becomes very important because already there is hyperinflated lung. If you give bag and mask or the child is excessively crying, there will be more air trapping, and again there will be more compromise on the unaffected side. Child may go for cardiac arrest. So whenever I am operating for a congenital lobar emphysema, I make it a point at the time of induction. I'm always almost ready to do an emergency thoracotomy if there is a problem with the intubation or the other parameters. Because it's very important. If there is a problem, I have to do just open up the thorax, the lung will come out and the child will be stabilized. Then the lobectomy can be done. So then I'm talking about CPAM, congenital pulmonary airway malformation. Previously it was called as CCAM, congenital cystic adenomatoid malformation. So this is more of a, rather than a surgical emergency, I get all this kind of patients from my fetal medicine specialist or my obstetrician colleagues for prognostication of the unborn child in an expectant mother. So nowadays in Bangalore city, we are seeing a lot of in vitro fertilizations, and they're all precious pregnancies. Now, when they comes with a CPAM in a 16th week ultrasound, this is the earliest we can pick up a fetal medicine specialist. Then we'll try to assess how severe is the CPAM condition. So usually it will diagnose in the maiden second trimester, but sometimes they pick up in the third trimester because when they investigate polyhydramnios, they'll come to know that this is because of the CPAM. So in antenatal USG, see, this is the lung with multiple cysts. It has shifted the mediastinum to the other side. What is more important is whether this lesion is deriving the blood supply from the pulmonary circulation or the systemic circulation. It is from the pulmonary circulation. CPAM is the likely diagnosis. It is taking the systemic circulation, then sequestration may be the likely diagnosis. So the classification is microcystic and macrocystic. So whenever there is a macrocystic, that means the diameter of the cyst is more than 5 millimeter, the child has got a favorable prognosis. If it is microcystic, then child have a poor prognosis because it appears as a solid hyperechogenic mass, and the ultimate lung will not be formed. The child will have a very bad prognosis when the baby is delivered. So antenatal counselings, if one lobe is involved and it is macrocystic, if there is no hydrops by 26 weeks, the prognosis is very good for the baby. The poor prognostic indicators are large size cyst, mediastinal shift, fetal hydrops, polyhydramnios, or other associated fetal anomalies are lethal to the baby. And invariably, I don't give a good prognosis to the unborn child, and parents will decide about for termination of pregnancy. So the presentation may vary. Many present in first week of life with respiratory distress, vomiting, or failure to thrive. Some children present late, maybe second year, third year of life. Once we diagnosed, the basic thing is a chest X-ray. We can see the left lung is normal. Right side you can see multiple cysts. We do CT scan to see the involvement of the one lobe or multiple lobes. Sometimes you can see air fluid levels. Once we diagnose CCAM, the child requires an emergency surgery as early as possible, because we have known that early surgery and involves the other lung to develop better, and long-term outcomes are better. So this lobectomy can be made by open approach or a thoracoscopic approach. So the unilateral lobe involvement have an excellent prognosis in CPAM children. So then we talk about the bronchogenic cyst. So bronchogenic cyst, so if you do an X-ray for any condition like a wheezing or a pneumonia, we can see a posterior mediastinal shadow. Majority of the thing because of the thymus enlargement, but we need a high index of suspicion to diagnose bronchogenic cyst, because majority of them are asymptomatic. We'll do incidentally, we're going to find bronchogenic cyst, or because of the child have recurrent lower respiratory tract infections. Then this persistent shadow on serial X-rays also we should suspect bronchogenic cyst. So then we should have whenever the posterior mediastinal mass is there, neuroblastoma is one of the differential diagnosis. Long-term complication of a bronchogenic cyst is bronchoalveolar carcinoma. Majority we can approach the wait and watch policy, but surgical exchange is mandatory. It can be done by 1 to 2 months of life. Thoracoscopy is very ideal to excise this cyst. So then I'm going to talk about the bronchopulmonary sequestration. It is a non-functioning lung tissue that lacks communication with the tracheobronchial tree and receives arterial blood supply from the systemic circulation. It is classified into intralobar sequestration, is very common, which is inside the lung without any visceral pleura, and extralobar sequestration, it is outside the lung with a visceral pleura. So clinical presentation depends on the intralobar or extralobar. Intralobar have more commonly gets infected and presents early part of life. Extralobar needs high index of suspicion to diagnose bronchopulmonary sequestration, but both of them present with repeated respiratory infections. So prenatal evaluation, as I discussed, it appears as a triangular mass just located near the lower hemithorax of the diaphragm, and it appears homogeneous echogenic mass, and the blood supply is from the systemic circulation. Whenever there is prenatal diagnosis of bronchopulmonary sequestration, the first thing what we're going to do is the chest radiograph. The chest radiograph, again, you can see here in the right border of the heart, some opacified lesion, that's a bronchopulmonary sequestration. In the lateral X-ray, we are seeing the same. So it appears as a dense mass. So when we do the CT scan, doing the CT scan, we should always see where is the blood supply is coming from, which part of the aorta. This is very, very important for the surgical approach and ligation of the blood supply to the sequestration before excising it. So symptomatic patients always require surgical excision. So intralobar sequestration majority of the times requires a lobectomy. Some papers have told about this segmental resection, but it is more complicated. It's not that easy. Lobectomy is far easier and outcomes are better. So thoracoscopy in the management of extralobar sequestration is very much ideal, where we can be, with the magnification, you can delineate the entire lobe, identify the vessel, clip the vessel, and resect the bronchopulmonary sequestration. So that's all. Thank you for the patient hearing. I'm ready to take some questions on this topic now.
Thank you, Dr. Mukund. Fantastic presentation. I think it's a very comprehensive, and most of the things which are relevant to us is covered. Fantastic.
Dr. Shivaji Mane is here. Is my teacher. Namaskar, sir. And my friends are there. How was the presentation, sir? If Mane sir says it's okay, I'll be more happy. Thank you for attending this my talk, sir, because I learned many of my pediatric urological procedures from Dr. Shivaji Mane.
Mukunda, I saw your name and that is why I attended this meeting.
Thank you, sir. Thank you, sir. Thank you so much. Thank you so much, sir.
Thank you, sir. Thank you for attending. And Dr. Mukund is very, very famous, and he's doing a phenomenal job in Bangalore. Thank you, sir. Thank you for attending.
Thank you, sir. Nice meeting you, sir.
We will move on to the next topic. So I request all the participants to post their question after the next talk, and we will go for discussion after that. So now I request Dr. NIJAGAL. Dr. Mukund, you can stop sharing the slides.
Yeah.
Dr. NIJAGAL. Yeah.
Sir, you look very.
Dr. NIJAGAL.
How to stop it?
Yeah. Dr. NIJAGAL. Dr. Nijgal, I think so. If any of you have any questions, close door, close door. If you have any of you have any questions till Dr. Nijgal starts, Dr. Nijgal?
Yeah.
Yeah.
Hi.
Can you speak a little louder?
Yeah. Just a minute. I'll just see. Hello.
Yeah. We can hear you. We can hear you. We can hear you. Think, can you mute?
தர்மத்தை நிலைநிறுத்த அதர்மத்தை வேறறுக்க போர் தேவை. ஆக போரை போதித்தவன் கண்ணன். போரை போதித்த கண்ணனை குறியீடாக்கி போர்
Yeah, Dr. Nijgal, kindly unmute yourself. Yeah, you can start sharing.
All the best for both the speakers. Very good, very good.
Are you able to see the slides?
No. I think I can see only the screen. You do one thing, stop sharing the slide. Share. Stop sharing the slide. Stop sharing.
Just a minute.
Yeah. Meanwhile, any of the participants, if they have any questions, they can pose the questions. We'll take the questions as well. Dinakar sir.
Just a minute.
Yeah, you take your time. It's okay.
I have a little network issue. Just a minute.
Yeah. If any of the questions have come up, you can start the discussion, sir. And then once Dr. Nijgal is ready, then we will continue the session.
No, just a minute, sir. It's just not getting present. The presentation is not coming on.
Okay. We can hear you. Yeah.
Prashant?
Sir, Dinakar. Yes, sir.
Questions can be asked. Can I ask questions?
Yes, sir. Please ask the question, sir. Till Dr. Nijgal is ready, we can take questions. Naresh, sir, go ahead, sir.
Yes. How frequently we come across surgical emphysema over the chest in neonatal pregnancy?
Can you go tall?
How frequently?
Yeah.
So please unmute.
How frequently we come across surgical emphysema over the chest in neonatal practice?
Dr. Mukund, sir.
Hello.
Yeah. Yes, sir. Can you repeat the question, sir?
Surgical dilemmas in neonatal practice.
Surgical emphysema, sir.
Surgical emphysema you're asking, sir?
Yes. I am asking surgical emphysema.
Emphysema. Okay.
The surgical emphysema is most commonly associated with the wrongly placed intercostal drainage, or when the intercostal drainage slips. When the fixation is not good, the air leakage happens from the pleural cavity into the subcutaneous phase and causes surgical emphysema. That was the question, sir?
Yes.
Yeah. So for the surgical emphysema, replace the tube back into the thorax and just wait for 3 to 5 days. The gas will be absorbed in the body. No need to panic at all. And I've seen when you do a thoracotomy for any other surgical condition, sometimes they give very rapid chest physiotherapy, or maybe they use chest compression when the child is very sick. Then also we see surgical emphysema. If you make sure that the tube is in place, whatever the gas collection the subcutaneous face, over a period of 3 to 5 days, everything will be absorbed. No need to worry about it. I answered your question, sir?
Yes, yes.
Thank you.
Mukunda, Dr.
Yes,
Mukunda.
Yes, sir.
One more thing to add to that will be the sometimes we get a emergency foreign body presenting with a surgical emphysema.
Yes, sir. Yes, sir.
Yes.
So whenever there's foreign body in the tracheobronchial tree ruptures, also we have a surgical emphysema. That's correct, sir?
Yes. Yes.
Yeah. So yeah, that's one of the other conditions where we had a high index of suspicion.
Sir, do we come across empyema in the chest in neonatal practice?
Yes, sir. Because I mean, I had done thoracoscopic decortication in as early as 3 months old or 2 months old. So we have encounter empyemas minimum 2 or 3 cases in a month in our unit. And earliest what I've done is in a 2-month-old baby having a very bad empyema, which was treated outside, and the diagnosis was picked up very late. And we had to do a thoracotomy, take the thick pleural pus flakes. The 2 months is the earliest thing what I had done for a decortication for a small baby.
Dinakar sir, if you have any other questions, you can ask, sir.
Yeah. Dr. Mukund?
Yes, sir.
Very nice topic. Really, dear.
Hello.
Dr. Mukund?
Yes, sir. Yes, I'm talking to you. Yes, I can you please ask me the question, sir?
See, I want to ask you two things. In
Yes, sir.
tracheoesophageal fistula,
Yes, sir.
what we read is directly if the esophagus is having more than 2 vertebra distance,
Yes, sir.
we have to pull the that upper esophagus and lower esophagus. What we will do, we will put it in the throat.
No,
Means upper esophagus, what we will do, we will put it near the throat and we will suture such that whatever the secretion is there, it will go out.
Yeah, that's esophagostomy. Esophagostomy, pulling the upper pouch into the neck to prevent aspiration pneumonia, and a gastrostomy for feeding purpose. This is a traditional way of doing a long gap esophageal atresia or a pure esophageal atresia.
Yeah, my question is, nowadays I heard some people are doing more than even 2 vertebrae at a time. They will do the operation. Is it true?
Yes, sir. What will happen? It is the subjective feeling when you mobilize the upper pouch and lower pouch during thoracotomy. That feel comes by the experience of the surgeon, whether I can do anastomosis without undue tension or it is long enough. It's a 2 vertebra, 3 vertebra is one of the method to communicate with the other surgeon. It's a long gap, but it's a subjective how that sutures are holding, how gap it is too much of tension, then we don't do the primary anastomosis. But I still feel long gap esophageal atresia. Primary anastomosis. Esophagus can't be replaced with any other. Child having a structured esophagus is far better than doing esophageal replacement surgery with stomach, colon, or jejunum. Strictured esophagus child will do better functionally rather than a replaced with some other organ. So that's why I was trying to give importance on the Fokker technique, where you do try to preserve the native esophagus, and it requires 2 or 3 surgeries. And once we do the surgeries, child may have a strictured esophagus. But we know that when you do sequential boogie dilatation of the esophagus, because in a small baby, every cell in the baby can have a growth potential. When you do systematic boogie dilatation of a strictured esophagus, a biweekly or tri-weekly methodology or intervals, we can preserve the native esophagus, the stricture problem can be corrected. If there is a stricture also, what will happen? The upper pouch dilatation will happen. Sometimes child may require one more surgery by 3 to 6 months of life and do resection of end-to-end anastomosis of the upper pouch and lower pouch and take out the stricture. So it sounds like multiple surgeries, but that has got added benefit where child will have a native esophagus rather than a organ which is not ideal to fulfill the function of the esophagus. I always in favor of a strictured esophagus rather than the stomach or a colon as a substitute for esophagus. And strictured esophagus, if you deal in the newborn period in a very aggressive way, that can be corrected.
Yeah. So what I am asking you is, 1 minute, I cannot hear you.
Yes, sir.
Suppose if it is even the maximum length at a time, how much? Because sometimes one surgeon, when I call, he will tell, sir, more than 2 vertebrae I cannot do. I will do the primary operation later. Once it grows, I will do. But same other surgeon, he will tell, I will try.
Because depends on the experience of the surgeon. Because if Manesh sir is there as an operating surgeon, he may have done around, I can tell you, around 5,000 to 6,000 tracheas or fistulas. Its comment is always important. I want to Manesh sir's comment on the long gap esophageal atresia. Sir, can you hear me?
Yeah, I can hear you. Can you hear me?
Dr. Dinakar is asking us, how do you say that it's a long gap, 2 vertebral bodies, and 2 surgeons doesn't opine the same length in the same child? How to deal with the problem?
It is extremely difficult to before surgery to exactly say what is exactly likely to be the gap. Though we can read the X-ray, lateral X-ray, if you put the catheter in the upper pouch, and then obviously we know the lower pouch is usually at the 3-4 level. But as you rightly said, it will vary from person to person. Anything more than 2 vertebrae probably one might find difficult. But as you said, at the same time, I routinely do what you call a circular myotomy upper pouch, where one circular myotomy can increase the length at least by 1.5 to 2 centimeter, and we can easily do anastomosis. And I am not in a 8 diverticulum because of that. So it will, as I said, it will vary from person to person. But whenever you find there's a difficulty in anastomosing, and you find a little bit tension on the anastomosis, the best thing is to put the same child on the post-op on a ventilator care, so as to avoid the unnecessary neck movement. So, and about the replacement, as you rightly said, that the native esophagus, other esophagus is the best. You cannot have other substitute. But at the same time, Foucault has got his own problems in our country, because it requires long-term hospitalization. You require a regular mobilization of the upper and the lower pouch. And more than the stricture, the other problem that you face with that beginning is the reflux. So eventually, most of them require anti-reflux surgery. And in a setup like at JJ Hospital, where I've been as a honorary there, we really don't practice that Foucault technique. But what we do is regularly at the age of 8 months after esophagus gastric to a gastric replacement. And it works for that. But he's got his own problems, but that is one of the safest that I've found compared to the colon or the other things.
Yeah, because that is the safest procedure, so I totally agree. But I'm me and Dr. Dinakar, trying to work on the Foucault technique, sir, because now I am taking the entire responsibility of the family, 3 to 4 weeks of hospital stay, multiple surgeries, financial conditions, socio-economic factors. I'm trying to do one Foucault technique and see how will be my experience. So once I do it, I'm going to share my experience with you, sir.
Yeah, and one more thing. Suppose if the tracheoesophageal fistula operation has been done, my question is very, very clear, Mukund.
Yes, sir.
Some neonatologists, and some other doctors are the surgeons. They will prefer, sir, within 2 days, you can remove, if the baby is fine, immediately you can remove the baby from the ventilator if it is not necessary. Some surgeons will tell, sir, keep it at least sedated for 1.5 to 2 days.
Yes, sir.
So some people will immediately remove. Some people will keep it for 2 days at least, or 1.5 day. Some people will keep 3 days. See, so many people have done a study on this,
Yes,
and
sir.
they have noted whichever the baby having agitation will have after giving the feeding will have either pleural effusion.
Yes, sir.
Milk once feeding starts, it will come in the pleura.
Yes, sir.
So what is your experience and what really I should do?
See, ventilator is not mandatory for a short gap esophageal atresia. Ventilator is not at all required. It is not mandatory. It should not be because of the because of the tracheal fissure. If child has comorbid conditions like a heart condition, or this, already child has already aspiration pneumonia, the lung is the criteria to ventilate, not the esophagus per se. I usually don't prefer for a elective ventilation when I operate for a tracheal fistula. I don't because it causes more problem than benefit. And the next part of the question is 2 days or 1 day, because when the child is ventilated, the neonatologist will take over and they decide whether to ventilate for 1 day or 2 day. But by my experience and my personal opinion is elective ventilation is not required when you do a tracheal fistula repair. I answered your question, sir?
Yeah. No. Sorry, I didn't get, and many people did not get. I am not asking only ventilator. I am asking even sedation or movement, because if the baby is more agitated.
No, sir. No sedations. No sedation is required. No agitation is required. You start the feed after 24 hours through a nasogastric tube. Only thing, only keep the child in a more comfortable position. That is more required than the sedation and all. I don't believe in sedation, and I don't recommend sedation or any other things to keep the child calm. So I believe in nice anastomosis. The anastomosis during the surgery is more important. There is a way to do the anastomosis. Take the posterior stitches first, then do the anterior stitches. Take delicate sutures. Don't do tissue trauma. And when you do less tissue trauma, the healing is excellent. I give more importance to the surgical part of the problem rather than the post-op care. So delicate dissection, small sutures, anastomotic techniques is very, very important in the outcome of tracheal fistula rather than elective ventilation, sedation, or any other things. Hello, sir. Hello.
I am hearing, sir. I am hearing.
Yeah, that's my take on the question, sir.
Okay, can I ask your senior once again regarding this?
Yeah, Dr. Shivaji Manesh, sir, please.
Hello. Can I add to that?
Yes,
sir.
I think there are two questions. There are two parts in your question. One is about sedation. The second is about the ventilator care. As Dr. Mukunda rightly said, we don't need to ventilate all the babies. Normally, most of the good weight babies presented early, diagnosed early, they can be managed easily without a ventilator care. Ventilator is required only if you find on technical ground while doing anastomosis, there is a little tension on anastomosis. Then one can think of doing up elective ventilation. At the same time, taking care that pressure should not be too high, that air should not leak from the sutured fistula site. So that is the only rarely that we need to do elective ventilation. And second, obviously, the child preoperatively itself is presented very late. They had a lot of aspirations because it's going to feed. And these are the babies, obviously, whatever you try to stabilize them preoperatively with a good chest physiotherapy, antibiotics, and all these things. Eventually, the chest is so bad, you might require even ventilator care before surgery. So they obviously requires post-operative ventilator care. Second point about the sedation. Again, routinely, we don't need to sedate them. Again, if you, during anesthesia, that is what we are practicing presently at least in my private practice, we give all these babies thoracic epidural catheter, and that is good enough for the postoperative pain relief. Once there is an epidural catheter for these babies, then you don't need to sedate them anything to take care of any pain. The most important part remains the post-op, and the that we instruct for the most of the pediatricians and the nursing care is that we don't try to extend the neck, so that you don't extend the neck unnecessarily. And when you do a suction, so throat suction, which is usually required in first 24 to 40 hours, see that your suction catheter doesn't go too much deep inside the throat because you can easily disrupt the anastomosis. So we usually mark on the suction catheter about 5 to 6 centimeter, and we tell the nursing to see that you don't introduce more than 5 to 6 centimeter from the gun margin. So these are the and third thing is of course the feeding tube or the rice tube, which is kept across the anastomosis, usually the small size feeding tube. We always tell the to the pediatrician and to the nursing staff that you by mistake also don't try and change the feeding tube in early post-op. So these are the important precautions that we take in the post-op.
Yeah, sir, very good. Dr. Mukund, just
Yes,
small
sir.
one doubt. Suppose
Yes, sir.
after starting the milk,
Yes, sir.
after starting the milk, if the baby develops respiratory distress, after taking the X-ray, we find or some milk is there in the pleural cavity,
Yes,
or
sir.
ICDT site milk is started pouring. How
Yes,
many
sir.
days we should keep NPO? Then how to proceed further?
See, the NPO is for there is a drain, an ICD drain in the retropleural space. Everything will come out through the drain. So we should treat it as a empyema and give a broad spectrum antibiotic. Keep the child NPO for maybe 2 to 3 days. Try to negotiate a rice tube along the anastomosis into the stomach. Give small amount of feeds. The NPO is depending on child to child, but majority of the leak is going to heal on its own. No intervention is required. Only the problem will happen the stricture. The stricture we have to deal with in an aggressive manner with a maybe once in 2 weeks dilatation has to be done to treat the stricture. The NPO status maybe for 2 days, then restart the feeds because that is very, very important. If you think it's a major leak, I don't hesitate put a feeding gastrostomy for a newborn for the nutritional purposes. That is very, very important. When the nutrition is given well to the child, the problem, the leak, the healing happens very fast. The requirement of antibiotic becomes less. The child will recover very fast. If there is a major anastomotic leak, I don't hesitate put to feeding gastrostomy only for the nutrition purposes. Because feeding gastrostomy is a very simple procedure, only one anesthesia is required. So depends on the amount of leak, I'll take a call about how to deal with the problem.
Yeah, if there is a major leak, if there is a how long you are going to keep the gastrostomy tube in the stomach once the leak is persisting? Suppose.
So the leak will heal. The major leak, anastomotic leak, will heal in anywhere between 2 weeks time. The ideal way of 2 weeks, 2 to 3 weeks, the major leaks. Then we do a barium swallow or a water soluble contrast swallow to see if there is any residual leak or not. If the feeding gastrostomy is there, 80 to 90% problem is solved because the nutrition is taken care of. That leak is going to heal in 2 to 3 weeks time.
Why I asked is, I know you people are corporate people.
Yes,
so because the patients are paying. Suppose in the government schemes, if the patient comes, we have to do in that limited budget.
Yes,
so
sir.
3 weeks, that is the reason I asked these questions.
Yes, sir. Because the leak, we had to be patient. So whenever there is a leak happens, we had to be patient and treat the infection. Nutrition is more important than the other things will take care by itself only.
Thank you. Over to Prashant.
Dr. Nijgal, you can start the session.
Can I ask one question, sir?
Sir, after this session, you can ask, sir. He's ready with the presentation. After this, we'll continue the discussion. Dr. Nijgal. Dr. Nijgal,
unmute, sir.
start the presentation. Kindly unmute Dr. Nijgal and start the presentation. Dr. Nijgal, press escape and unmute. Yes, unmute. Dr. Nijgal.
Yes, sir.
Yeah.
Answer screen.
Dr. Nijgal, you are there?
Yeah, Dr. Prashant, let Naresh Prasad ask the question till he comes.
Yeah.
Hello.
So,
Hello.
my question is, my question is, how frequently we come across hemangioma in the upper respiratory tract in neonatal practice, how to diagnose and how to manage this condition?
I have not, because I have not seen a hemangioma in the upper, in the airway. I don't have much experience at all. Because have you encountered any case, sir? Because I have never seen a hemangioma, because I worked in Vada Children's Hospital for 3 years as a trainee and 3 years as a faculty. In 6 years, no, I have not seen a airway hemangioma. Because maybe Dr. Shivaji Mane sir can pitch in and say that he's got any experience with a airway hemangioma.
No, I'm not seen a single case. Usually, if there is a hemangioma in the skin, then one should suspect probably the airway hemangioma or not. Again, needs a scopy or some form of CT scan, virtual bronchoscopy, to confirm there is hemangioma. The treatment is usually with the same way as like a beta blocker or the steroid therapy orally.
Hello.
Yes, sir. Thank you, sir.
So they are saying that when there is a hemangioma over the beard area, you should have a doubt about the upper respiratory tract hemangioma. Is it correct, sir?
Okay.
No, not necessarily always, but whenever there's somebody has got a cutaneous hemangioma and presents with some degree of stridor, then one should strongly suspect that probably it's got associated with a hemangioma in the respiratory tract.
Thank you, sir.
Oh, thank you, sir.
Dr. Nijagal, you're there?
Yeah, are you hearing?
Yeah, yes. Please start the presentation. I request all other to kindly mute themselves. I request all other participants and our other to kindly mute.
Okay.
Mute themselves. Yeah. Okay, Dr. Nijagal, please start the presentation.
Yeah, I'm Dr. Nijagal. I'm a consultant pediatric surgeon and a urologist. I work in a small place called Tumkur. I'm not going to the theoretical part of what we do in abdominal surgeries because most of us know it. I just want to discuss some case scenarios where we'll be able to know all the things. Prashant, are you hearing?
Yes. Go ahead.
Yeah.
Go ahead. Very clear. Go ahead. You can change the slide and you can go ahead.
Okay. Yeah. Coming on to abdominal distension. Whenever a neonate presents with abdominal distension, any neonatologist will always think of sepsis. So when we rule out if we rule out sepsis, what next? There is no sepsis after your workup, so we'll have to work up with a Hirschsprung's, which can be dealt with meconium history or a constipation history or a malrotation and atresia. When you want to diagnose with malrotation, you'll need some investigations which I'll be dealing with later. And an atresia where you need antenatal checkups, all the antenatal history and all you need to know. All these things we think of whenever a child is associated with bilious vomiting. And whenever you feel a mass in the abdomen, you need to slow.
Kindly mute all. Dr. Nijagal, please unmute yourself. Just press extension, escape.
Yeah, I did it.
Yeah, okay.
Yeah. Whenever you feel a mass in the abdomen, you should always think of a mesenteric cyst, duplication cyst, or a omental cyst, which is very rare in neonate. And ovarian cyst in if it is a female, or a hepatoblastoma, hemangioma of liver, which can be very huge, or a neuroblastoma, Hirschsprung's, Wilms tumor. There are varieties of cysts in the abdomen which can be seen, like splenic cyst. And coming on to the case scenarios, I'm not going into the detail of theoretical part. It's the first case scenario where we find a bilious vomiting since birth. Abdomen is not distended and soft, and antenatally there is a history of polyhydramnias. Then we need to get a ultrasound and an X-ray done. On the ultrasound you can see the double bubble appearance, as well as on the X-ray you can see a double bubble appearance, where it is diagnostic of duodenal atresia. So what we do in duodenal atresia as a surgical person is like resuscitation, maintain the electrolyte balance, then we'll further evaluate for other Down syndrome and all, then surgical correction with duodenostomy. But the usual surgical course will be a little difficult in these patients, what I usually do is I don't do a duodenostomy and come out. I usually put in a transanastomotic feeding tube through the stomach so that we can start feeding early, even if the duodenum, which is dilated, if it takes longer time to reduce in size and comes back to its normal peristalsis. Coming on to the case scenario 2, this is it's the where you have a bilious vomiting since birth, and you have taken an X-ray. You have just dilated stomach. The other part is not seen, where you don't see the air anywhere in the abdomen. Then we need to evaluate. Then we need to think in terms of the malrotation. Malrotation, we need to do a simple investigation like barium meal follow through or a barium swallow, whichever is comfortable, and we diagnose it with this kind of a barium swallow, where you have all the small bowel on the right side of the abdomen, and the duodenum never crosses onto the left side. And this is a classical presentation of the malrotation of the gut. And malrotation, usually child presents with bilious vomiting, a scaphoid abdomen, and abdomen will never be distended in these cases. So we usually neglect these kind of things. So we need to be very vigilant if the child has a bilious vomiting or a greenish vomiting and a scaphoid abdomen. That is almost always diagnostic of a malrotation in a neonate. So what we do in these cases is a latch procedure, where we eviscerate the whole bowel, we correct the volvulus if it is present, and we divide the latch bands as shown in the figure, which is attached from the duodenum to the colon, and we widen the isthmus of the mesentery, and we keep the duodenojejunum in the right iliac fossa and the IC junction in the left iliac fossa, and we do an appendicectomy. I usually do an appendicectomy, but many of the surgeons, they don't do an appendicectomy as a part of latch procedure. But classical latch, it is told that appendicectomy needs to be done. And if it is done, then we need to write it. Even if it is not done, because we keep it in the left upper quadrant, we usually should write whether we have done it or not. And malrotation with volvulus, this is a very risky thing to operate. We usually, when we do a barium swallow, you can see the corkscrew sign of the small bowel, where the whole small bowel looks like a corkscrew. And this is the intraoperative picture showing the classical volvulus of the small bowel, where you need to derotate the bowel, and then where you need to derotate the bowel, and the classical latch procedure will need to be done. And if we fail to recognize this condition, then it will land up in the whole of the small bowel, which will become gangrenous because of the blood supply of the small bowel is compromised. And coming on to the case scenario 3, it's a newborn baby, bilious vomiting since birth, and there is abdominal distension. Then we should think of, this is the classical presentation. This is how usually the neonate presents. There is abdominal distension, there is bilious vomiting, and it's a newborn. Then it will be a gasless abdomen which is seen like this. Then it is usually meconium peritonitis, where we see a meconium. There can be gangrenous part of the bowel, where you need to do a limited resection and a stoma in these children, and it's a little difficult thing to manage, because these meconium peritonitis is usually associated with cystic fibrosis, which can lead on to pneumonia and other complications in these children. Now coming on to case scenario 4, it's a newborn baby with a bilious vomiting since birth, and there is abdominal distension with palpable loops. There can be preterm or a term baby in this kind of a case scenario. So this is how the classical presentation of atresia looks. Like the distended small bowel in the center of the abdomen. The whole of the small bowel is seen, which is distended, and the distal colon is not seen. Distal colonic air is not seen. This is a classical presentation of intestinal atresia. So it is just like duodenal atresia, where we need to manage. We need to resuscitate the child, because the child might have electrolyte abnormalities and a surgical anastomosis, which is the most difficult, because as in the picture you can see, there is a proximal dilated bowel and the distal collapsed bowel. To manage these two with an anastomosis, it's the most difficult job, where we'll usually resect the proximal part for a long segment, where we can manage an anastomosis. And post-operatively, TPN is the ideal choice in a major center. But when it comes to tier 2 cities like where I'm staying, I usually put in a feeding jejunostomy, and I usually start off feeds on the second day. And TPN is a little difficult thing in peripheral sectors. So being a neonatologist or a pediatric surgeon in a peripheral center, I think it is a real daunting task to treat these atresias, because they usually take around 3 to 6 weeks to recover or settle down completely. And this is one more case where when I was in SCPJ where I operated this was a case preterm which had a jejunal atresia, where it had multiple atresia with an apple peel deformity of the thing, and where we had to resect these small segments and we had to do an anastomosis. Now coming on to the case scenario 5, this is the most important case scenario where we'll be missing most of the times as a neonatologist as well as a pediatric surgeon in a neonatal age group. The child presents with abdominal distension from 2 to 3 days of life, not tolerating feeds, and there will be history of delayed passage of meconium. That is, more than 24 hours, the child might have not passed stools normally. Normally, a child passes stools within 24 hours, at least a little bit of meconium. If it has not passed, that's a very significant history. And post for second or third day, if the child starts developing abdominal distension and it is not tolerating feeds, then we need to think of Hirschsprung's disease. So Hirschsprung's disease, it is the failure of the normal motility of the bowel due to the absence of normal meandric and the submucosal plexus ganglion cells. Nerve fibers are hypertrophied, and most oftenly it almost always involves the rectum, and it is usually called the classical Hirschsprung's disease. It can be an ultra short segment where it is involving only the anal canal, or the rectum, classical, a long segment till the splenic flexure, or a long segment or a very long segment, the whole of the large bowel is involved, or it is called total colonic aganglionosis. And even it can involve the small bowel also, but that is a very rare entity which I have not encountered till now. And gold standard for diagnosing this Hirschsprung's disease is a rectal biopsy. And this is a classical picture of a barium enema showing the distal collapsed bowel with a proximal dilated large bowel. And the second picture on the right hand side, you can see the classical collapsed large bowel, the distal bowel which is collapsed, and the proximal which is dilated. And usually we treat it with rectal biopsy if there are no ganglion cells, and if there is enterocolitis, consider a leveling colostomy. If there is no enterocolitis, then a contrast enema. Then proceed with the classical surgeries, which I'll be telling it later. And this is the intraoperative picture on the right hand side, where you can see the distal segment which is collapsed and the proximal segment which is grossly dilated. The proximal rectum is grossly dilated. And management, there are varieties of various approaches where we can do. If you have a frozen section, you always go through a single stage pull through. We always do a single stage pull through, which can be done as Suaves or Duhamels, whichever is comfortable for the surgeon, he can do it like that. But I usually, because I don't have a frozen and we have a very small, it's a very small setup, we usually do it in 2 stages, that is Duhamels or a Suaves. But I usually nowadays prefer Duhamels. When I was in MCH, I was trained for Suaves, but now I've shifted to Duhamels because that's the most comfortable and the most rewarding surgery for Hirschsprung's, whatever I have experienced. And now coming on to the case scenario 6, where you have a newborn baby, it has not passed meconium and a bilious vomiting is present and passing greenish urine. So these things might not be present in all the things, but usually they present with they don't pass meconium even after 48 hours. That's how I get a call that Sir, even after 48 hours, child does not pass stools in a peripheral sector. Because most of the times as neonatologists or pediatricians or a pediatric surgeon, we tend to forget to see the anal opening in a newborn. So we need to see an anal opening in a newborn. So this is a case of anorectal malformation where there is an absent anus. So this is how it presents. So that is why we should always see the anal opening. And X-ray, you can take a cross table X-rays, but that is a little difficult thing. You can take normal X-rays and you can look for the lower end of the rectum where it is present. If it is above the, we usually consider it as, if it is very low, it is considered as low ARM. There are varieties of things, but I usually consider it as low or high ARM when in my practice, because I don't usually have this cross table X-rays and all available. And if there is an absent anus, we should always look for various other abnormalities like vertebral anomalies, anorectal malformations, and cardiac defects, which will decide the prognosis. So we need to get an echo done before any surgery. And a tracheoesophageal fistula, this is very easy. As Mukund told, we can put in a Rails tube into the esophagus and we can take an X-ray and we can diagnose it. And a radial hypoplasia, which is a very difficult thing, which usually it is a radiological findings, and there can be limb defects, renal anomalies, where we can have varieties of things like hydronephrosis, VOR, neurogenic bladder. There are varieties of things which are associated with anorectal malformations. For all these things, before proceeding for a surgery, we need to get an ultrasound abdomen done. And last but not the least, and the most important, where we usually forget is the association of multiple atresias. These children can have multiple atresias like tracheoesophageal atresia, tracheoesophageal fistula and an esophageal atresia and a duodenal atresia or a jejunal atresia associated with an absent anus. But these are very rare things what I've seen in my practice. I have seen only some 2 or 3 patients like this, but only one has survived. And these are the classical presentations of low anorectal malformations, where you can there is a classical, the left hand side you can see the classical bucket handle deformity. On the right hand side, this is a low ARM where you have the meconium tracking towards this scrotum. This is a classical low anorectal malformation where you need to do an anoplasty. The case of perineal fistula, where we have done an anoplasty. And this is one more thing in females. You need to look for whenever there is an absent anus, we need to look into the vagina for the presence of an anus. This was pre-op. This is a little larger anus which you are seeing now, but when you are seeing in a neonate, it is usually seen as a very pin hole. So what we do is, we don't usually operate in the neonatal age group. We usually give them rectal washes, and then over a period of 3 to 5 months, depending on the comfort quotient of the surgeon, we usually do a PSCRP now. This is the final outcome of the vestibular anus posterior sagittal anorectoplasty. And this was a patient with high anorectal malformation. This is what I was telling, because I was called after around 4 days that the child is not passing stools because they had not examined the anal opening. So on the 4th day, I just went in, did a colostomy in a periphery, and a child had convulsions and sepsis. Somehow the child could make it, and child had we got an X-ray pre-op where it showed a hemivertebra on the X-ray, where you can see there is one vertebra which is only half developed. The other half is not developed. And we did a pull through at 6 months. And colostomy closure at 9 months. Coming on to case scenario 7, this is a very important thing, because most of the neonatologists, they come across these things. This is a preterm baby. This is a preterm baby with an abdominal distension and not tolerating feeds, altered NG aspirates. It can be bloody, it can be bilious, it can be the milk, whatever you are giving. And the cultures, when you see, it is positive, and whenever you send for a stool for occult blood, you will see the stool occult blood in the stools. So this is a classical picture of necrotizing enterocolitis, where you can see the pneumatosis intestinalis on the X-ray, where the air shadows is seen above the bowel wall. And this is the classical picture showing the pneumoperitoneum. And the left hand side picture is showing the ileal involvement. Only the ileum was involved, where we had to do a stoma. And there can be a very grave situation where we open this, these kits, and where we land up like this in necrotizing enterocolitis totalis, where the whole of the bowel is involved, where we can't do anything. That's a very, very rare situation. We have not seen much. 1 or 2 cases we have seen like this. So we should be wary of these things. And when we are dealing with a preterm with an NEC, we should always involve, we should be working as a team rather than individually, because sometimes we might pick it up late and it can end up with necrotizing enterocolitis totalis. This is a very, very rare diagnosis, gastroschisis. Even we couldn't save the child. I had got only 2 children where I was not able to make it survive. But this is the rare thing where you see the whole of the small intestines lying above the abdominal wall. It is all open. This is a very, very rushing emergency where you need to cover the whole small bowel with a polythene cover as it is used. I usually use a urinary catheter cover for these things. The management of these children are resuscitation and a surgical cover, where we usually tend to use a urinary catheter cover and a TPN and fluid and temperature control. And most of these children will go in for hypoglycemia, where we need to be wary of these things. And case scenario 8, where you have that is what I was telling about the mass, where these children, they're usually missed in the neonatal age group, because they don't usually present with any of the symptoms. But as age advances, they usually present with intestinal obstruction, where when we do an ultrasound or a Doppler or anything, where we incidentally pick up these things of a mesenteric cyst, where it needs just a resection anastomosis, and these usually do well. And this is one more thing, ovarian cyst in an abdominal emergency.
Sir, please unmute yourself, sir.
Hello. Yeah.
Yes, sir. Yes, sir.
Coming on to the case scenario 9, you have a neonate. With these children, they come with antenatal diagnosis of some cyst in the abdomen, and post delivery you find it okay, fine. This is a female. There was a cyst, so we got an ultrasound, ovarian cyst. So now what to do in this kind of situation? It's a little tricky situation to manage these kind of things. Usually when it is less than 4 centimeters size in a neonate, we usually tend to follow it up at 1.5 months. But at 1.5 months, if the size is increasing, then it needs an excision of the cyst. Even in a neonatal age group, if the cyst is less than 4 centimeters, but if the ultrasonologist is good and if he reports.
So sorry, again unmute, sir, please.
Hello.
Yes, sir. Yes, sir.
Yeah. If the cyst is less than 4 centimeters and if they report it as a complex ovarian cyst, then it needs other evaluation to rule out any ovarian CAs or teratomas. There are varieties of things which we need to do, like beta HCG, alpha beta protein and all. But usually when it is a complex cyst, we need to evaluate whatever the size of the cyst. If it's a very simple cyst, we can just leave it and follow it up at 1.5 months or 6 months. We'll see the changes of the size and the complexity of the cyst and then take decisions accordingly. This was a child which was operated at around 6 months. We had followed it up from 1.5, a newborn, from a newborn age. And case scenario 10. This is one rare thing where when I was in SGPJ, which I came across as soon as I entered SGPJ, which was an annular pancreas. This usually present with bilious vomiting and dilated proximal bowel. Whenever you take an X-ray, we'll not know anything. We'll just go ahead like as if we are doing a duodenal atresia. So this is a classical picture of a annular pancreas where this the pancreas encircles the duodenum like a ring. That is why it is called annular pancreas, and the proximal part of the duodenum is dilated and the distal is collapsed. And where we'll just do it like a duodenostomy, and these children usually do well post surgery. And this is one more thing which is very rare in our things, in our setup. In Karnataka, it has been very low. I don't know, probably the reporting is less, or we are missing something. We don't know exactly. This is a child. This is a child which usually presents with progressive direct bilirubinemia, where we need to evaluate. It can be biliary atresia or a colorectal cyst. Biliary atresia we usually tend to neglect. We just tell them, okay, fine, we'll use some vitamin K and all and UDCA. But usually when it doesn't resolve, usually we need to evaluate for biliary atresia. If it is not, if the child stools are white, but it has a mass in the abdomen just below the liver, we need to get an MRI done, even if it's a neonate. We have seen few cases of colorectal cyst presenting in the neonatal age group, where we tend to miss these things because these are very rare cases which will be seen in these areas. So I'm just stressing on it. And this is the intraoperative picture of a colorectal cyst with the gallbladder which is being removed. And this is one more case where we have a colorectal cyst. They usually present with increasing bilirubin and with cholangitis. Then we don't have a choice. Then we need to have a good interventional radiologist to put in a percutaneous transbiliary drainage for the relieving of these obstructions, so that it gets relieved, and after 6 months we can do a proper surgery of a colorectal cyst. And these images are from SGPJ, where we had good interventional radiology even for a neonates. And the other presentation of neonates is with vomiting. Whenever the child has some abdominal things, they have vomiting. So vomiting can be seen in cases of sepsis, malrotation, gastroesophageal reflux disease, atresia of the intestine, Hirschsprung's disease. Any mass in the abdomen can present with a vomiting, or urinary tract infections and PUJ obstructions, and there are endless diseases which can be discussed. But I want to discuss the main thing, like infantile hypertrophic pyloric stenosis, which usually present around 1 month of age, and it's a male baby. The vomiting will be projectile, non-bilious. Sometimes mother tells it is greenish in color also. Then we need to be wary of. We need to think both the diagnosis at 1 month of age, like pyloric stenosis, as well as malrotation if it is greenish. They usually have the very grave, very severe dehydration. There will be weight loss, there will be lethargy, and with IHPS, the child can even present with shock. And this is the intraoperative picture of pyloric stenosis. The left hand side is showing the pyloric stenos part, and the right hand side you're seeing the pyloromyotomy being done. There are some interesting case scenarios which I had seen throughout my career, which I want to share with all of you. This was a case, this was a neonate which at birth it was somewhere around 2.3 or 2.4 kgs when I was in SGPJ. This presented with a large mass in the abdomen. So we had to evaluate for, we thinking that this is a neuroblastoma, because usually the neuroblastoma is the most common thing which we usually think of in a neonate. Then slowly what happened, okay fine, we evaluated for the markers, we've sent for a biopsy, they also told it is neuroblastoma. Then we gave all the things, we gave the chemotherapy, all the things were done, but still the size of the mass didn't come down. So then we thought, okay fine, let's do a laparotomy and see it, because we didn't have a choice. Then we went in, when we went inside, this happened to be a gastric teratoma, where you can see the intraoperative finding on the right hand side. This was the size of the mass which was there in the baby. Unfortunately for this baby, post-operatively with the central line, child was infused milk, child went in for gangrene of the bowel, then we had to do a resection and anastomosis. First, initially we had to do a resection, then stoma, then the child had to come for closure of stoma, but the child is now doing well. And on the specimen, you can see the hairs and all, where you can classically tell us teratoma. This was another case scenario where you have an opening. There is an opening in the anal. There is an anal opening in the anus, but the child is not passing stools, and the child has abdominal distension and bilious vomiting. So now we need to push in a catheter, try to push it, try to do a dye study from below to look for rectal atresia. This is one of the rarest things where we'll miss, because there will be an anal opening, but there will be continuous abdominal distension. We'll be thinking of only sepsis. There are other conditions where we'll usually miss. This is what I told. There can be multiple atresias in these children. So this is one of the kids which had rectal atresia, where we had to do initially it was treated with a colostomy. Then we did a rectal anastomosis, and now the child is doing fine after colostomy closure. And this is one more thing which I was telling, omental cyst. This is a omental cyst, but this usually presents in the infantile age group. This is a large omental cyst which is present in the whole of the abdomen, and this is how the intraoperative picture will be. We usually excise the whole of the cyst. If the bowel needs excision, then we need to do a resection and anastomosis. And coming on to the other things, these are the challenging neonatal surgical cases which I have done till now for both the neonatologist as well as a pediatric surgeon. These 3 cases were a nightmare for me as well as my neonatologist. And the case 1 was a 25-weeker, 2 days primary with a primary hypertension with lower respiratory tract infection on non-invasive ventilation. Had received steroids because it was a primary and because it was a preterm, and was admitted for the HDU for dyspnea. Baby was delivered on 12th February 2017. Baby was shifted to NICU, which was a preterm with a birth weight of 683 grams. And this is the pre-op picture just before doing surgery. And child was kept on ventilator. There were features of sepsis from the 2nd day, which is normally seen in a preterm. In these kind of kids, the child was started on antibiotics, and day 6 there was worsening sepsis with septic ileus. And day 7 we had a perforation which was identified, and a glove drain was inserted in view of the distended abdomen to relieve the pressure so that the ventilation can be very comfortably done. And day 8 laparotomy was done on this kid, and we did a laparotomy. The findings were meconium filled abdomen with a large perforation in the distal ileum, and the rest of the bowel looked normal. So we did a thorough wash of the abdomen, and a limited resection of the ileum, and a stoma was done. Post-operatively, child was kept on ventilator and on parenteral nutrition. In day 11, we started on feeds, and the drain was removed by day 19. Child tolerated the feeds well, but from day 65, child started deteriorating. Child started developing distension even with a jejunal stoma, and child had vomiting and aspiration. So NEC stage 1 was considered, and it was treated conservatively. And the child was kept NPO for 10 days. For our luck, child didn't have any perforation, and the child was gradually started on feeds, and child underwent closure of stoma and is now doing well. And this was another case, which was a 32-weeker twins. These were twins. Twin 1 was delivered by lower cesarean section, which was weighing 1.5 kg. There was a gross abdominal distension on day 1 after starting 1 ml feeds. Only once the feeds were given, and there was a huge abdominal distension. So a neonatologist called me, and I asked for an X-ray which showed a large pneumoperitoneum. And sepsis screening was also done and planned for a laparotomy on 2nd day. And because it was a preterm, so we thought we'll rule out NEC also. And on laparotomy, abdomen was clean without any contamination, and there was a large gastric perforation of around 4 centimeters on the posterior wall of the stomach. So we did a primary closure with Weichel 40 sutures, and a glove train was kept near the anastomosis, and we closed the abdomen. And post-operatively, day 1, child was extubated and child was doing well. But I got a call that child developed again abdominal distension by 3 p.m. At around 6 p.m., we put in again a glove drain for as a temporary measure to relieve the pressure, and post-operative day 2, child was taken for re-exploration. And this was the post-operative X-ray where it showed a gross pneumoperitoneum. And there was a dehiscence of the gastric perforation closure with the infant feeding tube protruding through the anastomotic site was seen on re-exploration. So gastric perforation was closed again in 2 layers, and post-operatively, day 1, child was extubated and child is now doing well. On day 5, glove trains removed on day 10, reached full feeds by 20 days and child was discharged. And the case 3 is a twin 2, the same. The previous one was a twin 1, and this was a 32-weeker, which was a twin 2, which was weighing just around 1.2 kg. On this day 2 of life, there was abdominal distension. So my neonatologist called, an X-ray showed it showed a pneumoperitoneum. And sepsis workup was also done for this child in view of necrotizing enterocolitis, which was negative. So this is a picture which is showing pneumoperitoneum. And findings on a laparotomy, a small perforation in the mid-ileum was done. Mid-ileum was seen, and it was closed in layers and glove drain inserted. And on first post-operative day 1, child was extubated. 5th day started on feeds and reached full feeds by day 15. And by day 19, child developed abdominal distension and intolerance to feeds. So child was kept NPO for around 10 days with a diagnosis of NEC in mind, but we never had a conclusive evidence. But we treated conservatively with the hope that this is NEC and it will not progress to a surgical exploration. And feeds again started on day 10 and gradually increased and reached full feeds. Child is discharged and now doing well. So this is these 3 cases indicate spontaneous intestinal perforations in neonates. It suggests a perforation in the newborn without a demonstrable cause accounts for up to 7% of perforation in neonates. Etiology pathogenesis is unknown. Multiple theories have been told. Ischemia is the likely cause. That is what they are telling, but nobody knows the exact cause. The others which has been speculated are prematurity, asphyxia, congenital anomalies, stress at birth, vigorous respiratory measures, increased gastric pressure by distal obstruction, or anatomic abnormalities of the stomach. Usually happens between the day 2 and day 7 of life. This is what has happened in all our cases. And worst outcomes are male gender, metabolic acidosis, premature birth, and low birth weight. Luckily for us, everything has been good. Treatment is surgical exploration and repair or diversion. All the things we have done. Prognostic factors is timing between the onset of symptoms and surgical intervention is the only factor. Thank you.
Hello.
Yeah.
Nijagal?
Yeah.
Thank you,
Prashant.
Wonderful presentation.
I just wanted to highlight on the cases, whatever we miss. So that rather than telling about theory, okay, fine, this is what we see, what we usually miss as neonates and pediatric surgeons, I wanted to highlight it.
Fantastic presentation. Very good presentation.
Thank you.
Dinakar sir? One second. Yeah. So I think there was one question for Dr. Mukund. It's about the transportation of TOF baby. This was asked by PP Maya, our senior most neonatologist and most respected doctor. He had sent me a message regarding this question. How to transport a baby with TOF? What are the things which needs to be done?
One is hypoglycemia, hypothermia, and hypotension. Wrapping the baby, checking for a blood glucose. That's basic for any transport for any other condition. Especially in tracheal fistula, The culprit is the saliva which is pulling into the chest. The simple nasogastric tube putting at around 7 to 8 centimeter, intermittent aspiration with a 5 ml syringe or a 10 ml syringe is more than enough to bring the child from the site of delivery to the neonatal tertiary care. The utmost importance to prevent aspiration pneumonia is the prime thing in a tracheal fistula. Apart from that, you prevent hypothermia and hypoglycemia. This will that is more than sufficient to take care of that. Take care of the baby.
Yeah.
Intermittent aspiration of the upper pouch is very, very important during the transport if you don't have a suction apparatus in the ambulance.
Like interoperability through the gap.
Mukund.
Yes, Dr. Nijal.
Nijgal here.
Tell me, Dr. Nijal.
Yeah, the smallest baby where I have done a thoracotomy and decortication is around 20 days. Recently, in the lockdown period, I had done.
Okay. So,
I don't know what was the cause. We thought it should be some immunocompromised.
Yeah.
Luckily for us, child did well.
There is one more question. The scaphoid abdomen with bilious vomiting, how do you differentiate between diaphragmatic hernia from malrotation? And annular pancreas, how do you differentiate between scaphoid abdomen with bilious vomiting? How do you differentiate between diaphragmatic hernia from malrotation?
Sir, in a diaphragmatic hernia, whenever you auscultate, usually gurgling sounds are heard in the chest. In a malrotation, you don't see that. And a scaphoid abdomen, we always tend, with a bilious vomiting, we always tend to go with a barium swallow as emergency as possible, or else we'll post for a laparotomy. We don't even wait if we don't hear any gurgling sounds in the chest.
Okay. So if any of our participants has any question, they can unmute and ask. Yeah.
Sir, can I ask questions?
Yes, sir. Please, sir.
Sir, in cases of surgical abdomen, when a newborn is with abdomen, and we are asking for X-ray, do we suggest oblique and lateral views to explore more information from the X-ray?
Okay, ಮಾಡಿದ್ದೀನಿ.
In a surgical abdomen, sir, we are asking for mostly AP view. Should we ask for oblique and lateral view to get more information?
Yeah, Dr. Nijgal? Yeah, they have a question for you.
Sir,
Yes, sir.
Yeah.
Dr. Nijgal, are you there?
Yeah, I'm there.
Yeah, sir, Naresh sir.
Sir, usually we ask for a AP view of the abdomen in cases of surgical abdomen. Should we go for an oblique view and lateral view to get more information when we are asking for
exactly
X-ray?
When your question is coming, it's getting disconnected.
The question is,
see, any surgical abdomen doesn't need
lateral oblique view give additional information. What is the role of lateral abdomen X-ray in abdominal emergencies?
No, the thing is, see, when we are suspecting NEC or a perforation, any kind of perforation, we always ask for an oblique view. Otherwise, AP view is enough.
Sir, what is the importance of Cullen sign, that is the bluish discoloration of the umbilicus in a surgical abdomen?
Sir, in a surgical abdomen, any surgical abdomen, if you are suspecting, just an AP view in the initial stages is enough. If you are thinking there is a perforation or anything, then we always ask for an oblique view or a lateral decubitus view to look for the things. for pneumoperitoneum.
So if you are getting a bluish discoloration of the umbilicus, that is a Cullen sign in a neonate surgical abdomen. What is its importance, sir?
Probably, sir, usually bluish thing we have not observed any bluish thing other than peritonitis. That is what they tell. The Cullen sign is for peritonitis, not for these things, no, sir. In a neonate, usually we don't see that. Usually what they tell is, as a neonatologist, whatever I've heard is, you can see with transillumination, you can see pneumoperitoneum. That is what they usually tell. But I don't think so. It's always an X-ray, which is the best thing whenever you suspect any surgical abdomen.
Yeah. Sir, Naresh, sir?
Yes, sir. Yes, sir.
Yes, sir. Yes, sir. Any other questions do you have, sir?
May I ask a question?
Yes, sir. Yes, sir. Please, sir.
In a newborn, spontaneous pneumothorax, sometimes if we analyze the X-ray, we find minimum air, but respiratory distress is not that marked. How much pneumothorax need to be to deal with the ICD? If we keep it on oxygen, so will it absorb on its own, or is it must that one should put ICD just to drain the pneumothorax?
So the answer for the question is, if the lung volume is not compromised more than 20 to 25%,
okay,
if the work of breathing is not too much and child is maintaining saturation with around 2 liters, 4 liters, 2 liters to 4 liters of oxygen,
okay,
we can wait for 3 to 4 hours, see how the baby is responding to the conservative line of treatment. If the baby is deteriorating, work of breathing is more, is maintaining not sats with the amount of oxygen what you're giving, its requirement of oxygen is going up, then better to put an ICD and stabilize the child. But when I see a X-ray with a small amount of pneumothorax with a less than 20% volume, I don't jump into putting the ICD. I'll wait for minimum 3 to 4 hours to see the response of the child with a conservative line of treatment. If it is deteriorating in the next 3 hours because acidosis is building up with ABGs, the clinical parameters worsening, then I'll put ICD and keep it for 48 hours.
Is there any?
Thank you, sir. One more question, if you permit.
Yes.
In a baby, we are suspecting NEC, pneumoperitoneum is there, and distension of the abdomen is causing respiratory distress because pushing of the diaphragm and causing respiratory distress. In such cases, putting a peritoneal drain would help, or they directly go for this surgical intervention just to release the pressure in the peritoneal cavity. Can we put some drain just to release the distension? Is it feasible, or is it okay, or is it not be done?
Dr. Nijgal? Dr. Nijgal?
Yeah.
Yeah, Dr. Nijgal take this.
Sir, see, whatever you are telling is right, sir. We always put in a glove drain if the abdomen is distended, and if the neonatologist is not able to ventilate the child, to relieve the pressure, to maintain to resuscitate the child, if you need some time, then we can put in a glove drain and resuscitate the child, and then take it for a laparotomy. If the child is okay enough, even if with distension, if you are able to ventilate with minimal sendings, and if you can take the child for a laparotomy is the best.
Okay, thank you. Thanks a lot.
Thank you.
Sir, what is the importance of palpation and auscultation of a newborn in a case of surgical abdomen?
Sir, what is the importance of?
What is the importance of palpation and auscultation in cases of surgical abdomen in newborn?
Palpation.
And auscultation.
Auscultation usually, sir, the thing is, see, it's just like normally I have not auscultated much on the neonatal abdomen because we usually go with our intuitions. based on the antenatal history, postnatally, whatever the neonatologists say, what was the thing present. Most of the times auscultation will not give you much, except in a case of diaphragmatic hernia, where you hear gargling sounds in the chest. That's almost always diagnostic of a diaphragmatic hernia.
Hello.
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 Hello. Yeah, tell me, sir.
Can I ask two questions?
Yeah, please, sir.
Sir, what is the long-term outcome in babies operated for posterior urethral valves?
Posterior urethral, sir, basically there are varieties of presentations of posterior urethral valve. They can be from normal to a candidate for liver transplant. So it depends on the dysplasia and the identification of the PUV or dysplastic kidneys inside the womb. That's antenatally when it is diagnosed. If it's a later diagnosis, they have a good prognosis. If they are diagnosed very, very early in their age group, if they have a dysplastic kidney, if they have associated neurogenic bladder kind of a thing and all, then they'll have a very, very poor prognosis. It's a very, very vast topic where we need to discuss a lot of these things, sir.
One more question.
Yeah.
In biliary atresia,
in biliary
surgery,
sir, please repeat.
They say it interferes with the liver transplant in the later age. What is your opinion?
Sir, please repeat the question, sir.
Sir, in primary biliary atresia,
okay,
you do anastomosis, hepatojejunectomy. What you do?
Yeah.
They say this surgery interferes with if the child undergoes liver transplant later on. What is your opinion?
No, it doesn't. It doesn't interfere, sir. It's okay. You need to do it. See, the thing is, even if it interferes, anyway, liver transplant is a major surgery. These things are small hurdles which will not become a hiccup for a liver transplant. Probably, if you are thinking of not doing a Kasai porta enterostomy or for surgery, whatever surgery you want to name it, you can name it. I tell it as Kasai porta enterostomy. If you don't do a Kasai porta enterostomy in a child, whenever you diagnose it, at least whatever the 30% of the success rate, we might be missing it. Even if the child goes in for a transplant, if it's a little difficult procedure, we don't mind doing it because it's just taking out that liver along with that intestine and then anastomosing with the new liver. That's fine.
Okay. What is the incidence of GER? Sir, what is the incidence of GER following this tracheoesophageal fistula surgeries?
Sir, actually, incidence we don't know. Actually, we put all the tracheoesophageal fistula patients post-operatively on Domstal for around 9 months.
9 months.
We don't usually try to evaluate how many patients are there, whether they are vomiting or not. I usually put them on Domstal so that we don't have that aspiration and all issues because they would have had a major surgery. Okay. The exact incidence, even I don't know, sir.
Okay. Thank you.
Sir, what surgery is done for extrahepatic cause of portal hypertension in early age group?
Sir, what surgery?
When a baby has developed portal hypertension due to the extrahepatic cause, what should be the surgery required?
Sir, portal hypertension, extrahepatic cause. See, we usually have a varieties of shunts. So whichever, if you have a good liver with a very good Rex, you can go ahead with a Rex shunt. That's the ideal procedure if it's in a small child. If the Rex process is not proper, then you can do a distal splenorenal shunt. If the splenal vein is not proper, then you can go in for an inferior mesenteric vein and portal vein shunt. There are varieties of shunts where you can do it, but mostly we prefer, if they present at a very early age group, the Rex shunt.
Any other questions? Can you mute all? Yeah. Dr. Nijagal, you can unmute yourself now because there are a lot of disturbance. See, one more question which has come up is in case of spontaneous perforation in an extreme premature baby of intestine, when to wait if baby is stable what are the things which you need to look before taking up for the closure of the perforation?
Sir,
They're asking spontaneous closure.
Sir, the thing is, whenever it is a neonate, whenever you have done a perforation, whenever you are doing a laparotomy, if the abdomen, whatever I felt, because the child might not take up the anastomosis well when it's an extreme preterm, we don't usually try to do a anastomosis and come out. We usually do a stoma and come out, wait for 6 months to regain weight around 6 to 7 kgs, then closure. That's the standard protocol for a preterm. Because this child was 1.2 kgs, it was a very, very small perforation. I felt on table that it will get healed because the abdomen was not so much contaminated. It was a very clean abdomen comparatively. So we just did a small closure. Otherwise, in a contaminated abdomen, if we feel that, okay, fine, anastomosis is not going to take up, and because it's extremely preterm, I usually do a stoma and come out to be on the safer side.
No, if there's another scenario where we have noticed in X-ray gas under the diaphragm, even in ultrasound we have found out gas in the abdomen, but tummy is soft, baby is stable, and it has been just day 2 of life. Baby is passing motion, but still instantly you find in X-ray gas under the diaphragm, and you work up and you come to know that there is perforation. So in this scenario.
Yeah, that's what. See, whenever you see a pneumoperitoneum, we'll go ahead with a laparotomy. Even though the child is passing stools, just because the distal bowel is being cleared, it doesn't mean that the above things, whatever are coming down, are going down. Because of the perforation, it will.
All of waiting for spontaneous closure with momentum. That is what they try to. Sorry, your voice is breaking. Yeah.
Sir, momentum is momentum is not at all there in the preterms. A very, very small great momentum you might see, which might not be helpful at all. Okay. So we don't usually consider like an adult. We don't consider these things as an adult. It is a separate entity in a preterm. We usually tend to, whenever we do a laparotomy, most of the times we do a stoma and come out to be on the safer side, so that they don't end up in NEC and all those things. There are varieties of other things which will add on in extremely preterm units.
Okay. Participant, if they have any questions, they can unmute and they can ask. Meanwhile, there is one more question for Dr. Mukund. Yeah. Sorry. Anybody wants to ask?
Yeah, what is the easy way to differentiate between the upper type of anastomosis, this imperforated anus, and the lower type? How to differentiate between upper and the lower type of anastomosis, this imperforated anus?
This is for whom?
This is abdominal emergencies. Perforated anus, high and low. How to differentiate? They're asking.
Sir, it's It's basically the X-ray where we tell it as PC line. Above that PC line will be like high ARM. Below the PC line will be a low ARM. But we conventionally we don't do a cross table, prone, lateral radiograph most of the times. If we do that, then I can demonstrate the PC line and all.
Yeah.
So it's above the PC line. If it is there, it is a high ARM. If it's below PC line, it is low ARM. But we usually arbitrarily take it as low ARM if the meconium stain is there or a bucket handle deformity is there, as I showed you in the picture. If it is not there, we usually consider it as intermediate or high ARM and go ahead with the colostomy.
Okay, thank
you. Do we come across, sir, do we come across mesenteric cyst in neonatal practice? Mesenteric cyst, sir.
Mesenteric cyst we have not come across. See, these things I just told as a abdominal emergency. I just told it's not a neonatal emergency. Sometimes there might be small cysts which they'll tell mesenteric cyst on the CT or ultrasound, but we usually follow it up with till the child has symptoms. We usually don't operate in a neonatal age group. We usually wait till 6-7 months of age. Only then we'll try to operate on a mesenteric cyst unless obstructed. They can be there in neonatal age group, but they are not usually identified because we don't evaluate for mesenteric cyst in every newborn. because they usually don't have any symptoms.
So does the urachal cyst or vitro-intestinal fistula present as an emergency?
I didn't get you. Tricky. Sir, question please.
So does the urachal cyst or vitro-intestinal fistula present as an emergency in neonatal practice?
Neonatal practice as of now we have not seen much, sir. Only thing is vitro-intestinal duct or the which connects the bladder, the medial urachal cyst, that is what we tell. Urachal connections, they usually present with the urine leaking from the umbilicus. Very rarely we have seen, or there may be discharge. That's all. Otherwise, we have not seen this much in neonatal age.
Yeah. Anyone has any other questions? There is one more question for Dr. Mukund. How do you differentiate the clinically the milder form of CLE and pneumothorax? If baby is clinically stable, when to get when to press the panic button or when to go for the surgical intervention?
See, nowadays, every pregnant mother will go anomaly scan at 20 weeks of pregnancy. And invariably, a good fetal medicine specialist, when do anomaly scan or by third trimester, they'll give a hint that there is an ongoing problem. This is one case scenario. If other case scenario, child coming late with recurrent respiratory tract infections. In the first scenario, when you have a suspicion that something going on in the lung, we get a chest X-ray immediately after child is born. Not immediately, maybe around 6 to 12 hours after birth. That will act as a baseline. How bad is the CLE? And the CLE, it is a air trapping mechanism because of the bronchial problem, maybe a partial obstruction, the bronchial cartilage is not there. It's an ongoing process. So immediately after birth, if you see some amount of air trapping, you can counsel the parents that this is the problem and take a serial X-rays in 2 weeks interval, and you can solve the problem by first month of life. Or the second scenario, the incidentally detected CLE after birth, if there is quite a bit of air trapping, there is pleural herniation to the other side of the lung, and there is compression of the lung, there is mediastinal shift, then an emergency intervention has to be done to correct the problem. I hope you answered your question, sir.
Yes, sir. Yes, sir. Yeah. So, yeah, I think most of the things are covered. Is there any other questions from our participants? See, most of the time in our neonatology practice, we come across NEC, we come across pneumothorax, we come across CLE as well. At least yearly 1 or 2 CLE we do pick up, and malrotation, intersusception. So I think most of the things have been very comprehensively covered. And what exactly we want as a neonatologist, and especially the counsel the parents about the outcome and how it's going to be life after post surgery, especially for the parents. Tracheoesophageal fistula, once it is done, if it is too tight, what are the complications we expect, and how the parents need to cope up. Beautifully, it has been explained. So thank you very much. So before we leave, we give one last opportunity for all the participants. If they have any doubts, they can unmute and they can ask. After this, we will close the session. I think.
Hello.
Yeah.
Hello.
Please go ahead.
Sir,
Please.
I'm Dr. Kavita from Delhi. Sir, in case of NEC totalis, when you see the gut, or in any case when you're seeing that the length of the gut is not compatible with the life, so what do? You leave it there, or like you will resect it? Which way to go about, sir? Because we were stuck in a baby once. So would you be resecting the gut and closing it, or you will be just leaving it there because it's not viable even if you leave it, close it, resect it, it's not compatible with life. So how do you go about it, sir?
No, we usually, if it is not good enough length,
Yes.
for the survival of the baby. We usually just close the abdomen, and I usually counsel the parents that
Okay.
it is not compatible with life.
Okay.
It's not worth it.
Yes, sir. Yes, sir. Okay. Thank you. Thank you, sir.
Yeah. Is there any other? Yeah.
So
Even
in cases of in cases of undescended testes, what should be done?
Sir?
In cases of undescended testes, sir, what should it, can it
Sir,
present as an emergency?
undescended testes, they usually don't present as an emergency unless there is torsion. If there is a torsion, then they'll present to you in the neonatal age group with a pain in the scrotum. Means excessive cry. That's what is called pain in neonates. Other than that, they usually don't present it as an emergency.
Thank you, sir.
Yeah, fine. I think we had a wonderful discussion of both thoracic and abdominal emergencies. So we would like to thank Dr. Mukund, Dr. Nijagal for their time and patience and the eagerness to teach. Thank you very much. And we would like to thank our Dr. Mukund's guru. We have just celebrated Guru Purnima, and thank you very much for joining us, sir. Dr. Mukund, may I know his full name? Your Dr. Shivaji.
Dr. Shivaji Mane.
Dr. Shivaji, sir. Thank you very much, sir.
Is
Thank you
it-
very much for joining, sir. It's our privilege to listen to you. Thank you, sir. Thank you.
Thank you, sir.
Have a great day. Good night. Good night. Good night. Good night. Bye.
Thank you, sir.
Bye. Bye.